I'm just going to make sure. Thank you for that introduction. I'm just going to make sure I am sharing the correct thing. Here we go. Hopefully you can all see my screen. Yeah, thank you so much to the One HealthTech team for inviting us to speak today. We're going to share a few reflections from our experience of bringing service design and service design approaches into NHS teams, and particularly our recent work with University Hospitals Birmingham on a number of different pathways. And my name's Laura Smith. I'm a designer and researcher with a company called Unboxed. I'm here with my colleague Saskia, another designer. We are a digital product and service development agency. We've spent the last 20 years or so working mainly in the public sector with local government, central government, and with NHS teams to improve experiences for people using and delivering public services. So something that you might all heard of that we built and maintain is the UK government petitions website. We then adapted that for Scotland, Wales, and the state of Jersey. We are all about helping big picture thinkers solve knotty problems, and I'm very pleased to have one of those big picture thinkers with me today in the form of Dr. William Bradlow. So I'm going to ask him to give a bit of background to how he came to work with Unboxed before we get into the rest of the talk.
Brilliant. Thanks, Laura, and thanks very much to the organisers for this opportunity to speak. So I'm a cardiologist. I work in Birmingham, and for some time I've been following the story of SH24, which, for those who haven't come across it before, is one of the two largest digital sexual health companies in the UK. And I think what interested me so much in the company was their kind of founding story, which was of a public health and sexual health clinician who came together. They were very much overrun in terms of their service by huge demand, and they knew that there was a better way. And they saw that if they could deal with the sort of low complexity problems more easily, that they could then focus and turn their attention towards patients who had more complex needs. So they reached out. This was a large hospital trust in London. They reached out to their charity funder, who was prepared to give them a very large amount of money to create this digital service, but said, we won't release it until you speak to the design council and essentially include design thinking and service design in what you're doing. And I just thought that showed an awful lot of foresight on the part of the charity, and the company really flourished ever since. And this is some of their very early prototyping that they did when thinking about how to collect samples. And it was through SH24 and that early work that they did in partnership with Unboxed that I came across Laura, Saskia, and their colleagues. And the timing was about 2.5 years ago, and it came at a time when I'd been very, very heavily data focused and AI machine learning focused, and was really struggling to make any progress. And I sort of knew at that point that I needed to be more relational with the people I was trying to help and the people I was working with in order to progress. So it has all worked extremely well. Next slide. So why service design? Well, I mean, I guess my interest is in part because as a teenager, this is going back a long time now, but I did craft design technology at GCSE and loved it, and then ended up in medicine, and obviously moving a long way away from the design era, but always kind of retained an interest in the subject. But I think maybe without being able to articulate it, I was really frustrated by just how clunky everything felt. And service design seemed to offer an answer to that, not just for the people delivering care, but most importantly for the people using it.
Okay, thanks, Will. So just before we go on, I know there are probably quite a few designers in the room, but some of you are maybe less familiar with service design. So we heard Jasmine talk about human-centered design. Service design is a kind of an aligned discipline. So I'll just give you a brief explanation of what that means. So a good example of service design is the passport service. So some of you will remember what it used to be like going to get your passport. You had to go to the post office, ask for a form, go somewhere else to get a photo taken, fill in a form, send that form by track post. I can't even remember how you paid for it. Maybe it was a postal order. And then you just had to wait and hope that it would arrive. It was quite stressful. There was a lot of gathering of information. You had to physically go to different places. And now you can do it all on your phone. I have even done this while making dinner. If you've got a passport or driving license already, you don't even need a new photo. And if you still prefer an offline service, that is still available. And all of that happened because the designers working in the Home Office looked at the whole service, everything that needs to happen to get you your passport, from what you need to do as a citizen to what needs to happen inside government in terms of validating and your information, printing a passport and so on. And they crucially didn't just replicate the paper form or the offline service, they completely redesigned it around the way that people actually behave to make the whole thing much easier and more efficient for everyone. So service design is a term that has been around since the 80s, but it only really bedded in UK government services with the establishment of the Government Digital Service around 15 years ago, and with the work that Lou Down and others did to embed this approach in public services. Unlike Will, I didn't study design at school or university. I came into design having spent 10 years working in the voluntary sector and with social entrepreneurs. And these are some of the things on the screen that really excited me about design and solving big, complex social problems in a different way. So the work of the UK Design Council in healthcare, Sarah Richards' work in establishing the content design discipline in government, which was my way into design, and the whole approach of the Government Digital Service. And here, the card on the red, I don't know if you can still see me, but I'm actually holding up the box of those cards, which were created by the Design Council around different design methodology. And that's showing the double diamond. Some designers argue about how useful the double diamond is, but I still find it extremely useful to explain a process of divergent and convergent thinking, which is what we do as service designers: open up thinking and explore a problem, and then refine that thinking and understand what problem we need to solve. And we aim to look at the whole service from the moment a person enters it to when they leave, when they get blocked, or maybe in healthcare when they enter follow-up, and everything in between through this process of zooming out and then zooming in back in to tackle those problems or explore opportunities. And it is an approach that's very much based on collaboration, iteration of ideas, and crucially, being comfortable with uncertainty, particularly in complex systems like the NHS. We never go into a project knowing what's going to come out at the other end, but we rather carefully build up the relationships and conversations and testing of ideas and assumptions that helps us find the right problem to solve and the next person we need to speak to help us solve it. Again, just touching on something that Jesmond said, what often happens in the NHS is that services are pieced together around operational structures rather than the people that use them. Technology is procured and services are expected to adapt to it rather than the other way around. Staff and patients are not involved in developing the products they're expected to use, so we end up with workarounds like this one, people creating their own solutions for things that they actually need. So over the main part of this talk, we're going to talk about a few examples of approaches we've taken with different challenges in healthcare.
Great, thanks, Laura. So, our first theme is this idea about Avengers Assemble. And to give you a bit of context, the main patient group I look after are people with inherited heart disease, but specifically one called hypertrophic cardiomyopathy. This is a condition that causes thickening of the heart, and it can lead to, amongst other things, sudden cardiac death, heart failure, and atrial fibrillation and stroke. Now, a key part of management of families with hypertrophic cardiomyopathy is the process of genetic screening, if there is a gene within the family found in the affected person with which other family members can be tested, or diagnostic testing in the form of heart tracing and a heart scan. So in theory, it sounds pretty straightforward, but Laura, if you go forward. in practice, things are entirely different. So this is a real Teams message I received from a tech-savvy colleague of mine whose father had been diagnosed with the condition. She knew from him that he needed to be screened. He'd given her a letter to take to her own GP so that she could be referred to a specialist. And as you can see, that action didn't have a desired outcome because the GP basically brought her in to do an ECG themselves and assess them at odds at what they'd been asked to do. So this was our first project. We were funded by UHB Hospital Charity to essentially scope the problems associated with managing this condition and managing the screening process. And one of the things that struck us early on in this process is that essentially we're asking somebody soon after they've been diagnosed with this potentially serious heart condition to cope with the stress of that diagnosis and all the adjustments that come with it, but at the same time to become a messenger on our behalf to ferry and communicate information from our team to their relatives about the need for screening. And not only is this really stressful, as I mentioned before, it also definitely falls under the sort of clunky headline because it's generally done with bits of paper and email, and it just takes an enormous amount of time to get done. So this is what it can feel like for a relative who hears about a diagnosis of hypertrophic cardiomyopathy in the family and is motivated to get checked themselves. So the first thing is obviously there is a good chance that the relative who's affected might not tell their family member. This is specifically first-degree family members, so it's siblings, parents, and children. But they might not get told that they need to get checked. The next thing is they might go to the GP with the information provided by the specialist team to their relative, and just like our person, not get referred to specialist services for screening. The next step where things can go wrong is that they make their way to specialist services via a referral from their GP, but the really crucial bits of information that we need as a specialist team receiving that referral to decide how best to test the relative might be missing. So those are who the affected relative is, how are they related to the person who's been referred, what type of condition do they have they been genetically tested, what's the result, and have they given consent to share that information. Finally, there can be delays in the person getting tested, and if they are found to have the condition, they can be delays in them being passed on to specialist care to be fully assessed and risk stratified. So at the moment, it's a really messy system, and this is kind of a description of where we find ourselves, which is nationally, I would say, screening is disjointed, delivered across several services and hard for people to navigate. There's no doubt in our mind that this will be impacting on how many people take up the offer and of an invitation to be checked. And a key thing is that it's really difficult to collect relevant data related to the process. So it's been, I mean, this process is actually sat currently with the UK National Screening Committee, who are evaluating whether it should be formally recommended. But part of what is hampering that evaluation is the fact that data on the service is very, very limited, which not only makes it difficult to know where we are now, but also makes research which might improve screening in the future hard to do. So I mentioned Avengers Assemble at the beginning, and this is really what we needed to do for this work, because as I mentioned, it's really a service that's delivered across 2 different trusts, across multiple departments, as well as a genetics laboratory in Oxford. So there were a lot of different people who needed to being brought together for this project. And that meant we needed to use methodology, as shown in these photos, like visualization and mapping, to fully understand the existing journey. And it wasn't just enough for me to tell colleagues from Unboxed what the journey was like. We really needed everybody in the room because there was a lot of confusion initially. And then we needed those folks there to tell us about how we were doing in terms of iterating and starting to produce a better journey. So literally, in these pictures, we're asking staff to look at the journey, challenge what we've said, and see how it can be improved. And in there, you've got an array of people. You've got secretarial staff, you've got R&D informatics staff, there's somebody I can see from our local genetics laboratory, there's one of the senior people from the Genomics Medicine Service Alliance, there's somebody from the familial hypercholesterolemia team, basically a wealth of people who are closely and loosely involved in the process. And what we came to was an entirely new pathway that importantly was community-based so far as we could make it, was primarily led by specialist nurses and genetic counselling colleagues, and was supported both by a digital platform but also a number of digital tools that we were able to prototype, including one to gather the family history, one to connect family members to the affected individual with their consented information relating to genetic results and their diagnostic results. And that will allow us to track whether people have taken up the invitation to take up screening, and also follow through the entire process, the results of screening tests, and for those that are found to have the disease, how severely affected they are. So it was, for us, it brought together several themes, as I said, around prevention, being community-based, but also making best use of data.
Cool. Hi, guys. The reason we chose this second title about making people feel something is to highlight the power of creating an emotional connection and create empathy with the users of the service, and how we play that back with our team. We as designers, we usually do this through user research, gathering a deeper understanding of what users actually want, how they behave, when using storytelling and visuals to help clinicians do this, and other stakeholders connect with what we've learned. A big part of this is obviously the clinician-designer relationship and experience. One thing that we've found working with Will and other clinicians is that clinicians care very deeply about their patients and the quality of care they give them. But traditional doctor-patient relationships sometimes make it hard to do this and to understand this. It's hard to hear how patients really feel. Obviously, sometimes in that environment, clinicians with patients in a clinical setting, it's not super easy for patients to express sometimes how they really feel. And part of user research is really powerful in bringing these perspectives together.
Sorry. Thanks, Saskia. So just to give you a couple of quick examples of this. So we, several years ago, developed a remote monitoring service with Guy's and St Thomas's in London for people with long-term rheumatological conditions. People have been living with these conditions for years, and it allowed thousands of patients to report their symptoms every month using their phone, helping their care team build up a more holistic picture of their health over time, so they could see when people were in flare, when they needed help, rather than just seeing them when the booking system decided that they should have an appointment. After the service been running and successful for some years, we were asked by another trust to have a look at using it for patients with type 1 diabetes. So another long-term condition people live with their whole lives. They wanted to use it as a solution for something you may have heard of called PIFU, or patient-initiated follow-up, an NHS-wide initiative to try and encourage patients to take ownership of when they need follow-up and reduce unnecessary follow-up appointments. So we said, yeah, but we want to go out and test this service with users because it's a very different group of users. We want to go and see them at home, see them use this alongside the other technology that people with diabetes use to manage their condition. And what we found from this testing was that patients would quite like this service, but not for the reasons the clinical team thought. It would definitely not encourage them to reduce their follow-up appointments, as the reasons they wanted to come in for follow-up, even once a year, once every 2 years, were often much more emotional than clinical reasons. They really wanted to know that they weren't lost to the system, and this was their one touch point, and that was their biggest fear. So we played that back to the team at the trust, literally using the patient's voices, and that prompted a discussion which helped the team actually find an internal solution without wasting any money on getting us to build this. So by sharing that voice, we really challenged some assumptions they'd made about what patients really needed from that service. Another example, again, we were asked to adapt this remote monitoring service for people with long COVID. This was at a time not long after the pandemic, when the healthcare profession were really still learning about long COVID. Many patients felt completely lost and hopeless, struggling with multiple systems, finding no answers, going to GPs who were still learning about this condition. There's very limited research on it. And when we tested the service with them, we found they really weren't ready to self-manage. They were completely overwhelmed by their situation and had not come to terms with their condition in a way that would allow them to respond in a useful way to a self-monitoring, in the same way that, say, somebody who's lived with a rheumatological condition for years could do. In fact, many of the people we tested with told us they would give entirely false answers because they thought it would get them seen faster. They would rate their mental health as low as possible because they knew that that might trigger something that would mean they'd see anyone that they could talk to. So again, when we played that back to the team, we were able to put that voice in and say, look, I think you're trying to solve the wrong problem here. And that meant, and they went away and did something else. And it was an extremely difficult project for us as researchers as well. Those conversations were very hard to listen to. But trying to get that empathy and that emotional connection with the needs of the user meant that the team could go away and make much better decisions about how they could help them.
So leading on from what Laura was saying, when you're doing user testing, you never know how someone will respond to what you put in front of them. That's kind of a bit from what I've got here on this slide. For example, you can have a lighter, which was designed obviously to light candles, but a lot of people use it as a bottle opener, or a credit card that doubles as an ice remover, not in this weather, but when you're late for work. People respond to what you place in front of them in unexpected ways. And I personally had an experience with this. I was working on a project around Parkinson's and delivering a kind of digital prototype, delivering information to people who are newly diagnosed. When we were first designing it, we expected that it would be the person with Parkinson's who would want to interact with this information. But actually, when we placed it in front of them, they were with their spouses, and it actually turned out that it was the spouse of the person with Parkinson's in many of the interviews, which took over navigating the prototype. The really big takeaway from this is that you can create a prototype or a kind of artifact with one functionality in mind, but you never know what will happen when you put it in front of something. And that's really important, is to do that early on in the process and to feed those findings back to the team. Leading on from this, this goes back a little bit now to what I was saying at the start about how we communicate user needs back to clinicians and other people working in the team. There are really complicated dynamics when it comes to a patient or their family's response to a condition. People can have drastically different responses. Their relationship with their or a family member's condition can be very varied. For example, some people might not want to know any information when they're first diagnosed. They might want to shut that part off and focus on different areas in their life. Conversely, some people really want to take ownership and respond by it through seeking out information, having visibility on what's going on in theirs or another family member's care. These relationships with a condition between family members are complicated, and it's been an interesting learning for us that it's important not to make assumptions about what people's reactions may be, and also feeding these findings back with the team. As I said, particularly with showcasing clinicians how patients feel and relate to their condition is really important.
Great, thanks, Saskia. So the next theme that emerged from this work is this idea about designing in data. So as I mentioned, I was very focused on data collection for a long time in our service, and we've kept a registry for the last 10 years or so, but was struggling to get wider adoption because it's just too difficult to do. And I'd sort of modelled, if you go to the next slide, I'd modelled on a chap who I will speak about in a second. But first, I just want to touch on the on our most recent project. So I, as well as looking after people with inherited heart disease, work with members of the neurology team. And we look after a group of patients with neuromuscular conditions that can also affect the heart. And the largest number of patients that we look after have something called Duchenne muscular dystrophy. So Duchenne muscular dystrophy is sadly a severe progressive disease that is often diagnosed in early childhood when a child, for example, might struggle to get off the floor because of the way it affects the arms and the legs. During teenage years, walking becomes progressively more difficult until ambulation is lost altogether. The condition also affects the muscles of the heart, meaning the patient has to have regular heart checks and may need and often needs medications to stop the heart getting worse or weaker in the future. But they also need support for their respiratory muscles in the form of non-invasive ventilation. Now, despite decades of progress in the care of these patients, somebody with Duchenne muscular dystrophy in the UK today will unfortunately only survive until their late 20s on average. So I mentioned a cardiologist before who had sort of modelled my early ideas around the registry on. So this is a chap called Paul Wood who was working in London in the 1940s and 50s. And sort of as close to a rock star as you can get in cardiology, literally wrote the book on cardiology and then left it on a train and needed to rewrite the entire thing from memory. But as well as the book, he published a series of first of their kind papers, such as this one from which a figure is taken in the bottom left-hand corner. So this is a graph which on the x-axis has patient's age and on the y something called grade of effort intolerance, i.e. how difficult do they find normal physical activity. And this is for 350 cases of people who've got an atrial septal defects. That's a hole in their heart. And essentially, he was the first person to describe this relationship between increasing age and finding exercise more difficult for this patient group. And the way he went about doing it was with this database system, which is very much in the pre-computer era, called a notch card system. So it worked like this. Each patient was given a card with a series of holes running around the periphery of the card. Different conditions had different holes, as did different features of the condition. And when a person in front of him had a specific condition, he would clip out the piece of material lying between the hole and the edge of the card to create a notch. He would do the same for the features that were present. And what that meant is he could use a knitting needle, as shown in this picture here, to pull out all of the patients that he'd ever seen who didn't have a specific condition that he was interested in, leaving only those remaining in the box who did. And he could do the same thing to find specific features that he was interested in. So within seconds, he could start to learn from all of that experience that he'd gathered over the years. So if we fast forward 75 years later, there are clinicians up and down the country who are, I think, fair to say, similarly ambitious, hardworking, curious, keen to learn more about the condition through the patients they look after. Obviously, we no longer have the notched card technique, but we've still got clinicians doing the hard work of shepherding data. And in general, what they're doing is shepherding it into clinic letters. So this is just a sample letter of a patient with Duchenne muscular dystrophy, listing all the relevant disease features as well as the medications they're on. And essentially, by and large, the data remains there until either the clinical team or maybe researchers at a later date come back and extract that information retrospectively. The situation's slightly different where there's an audit team, for example, and there's data that goes into a national registry, but that's not the case for a lot of these rarer conditions. And through that type of research, you can get really important information like colleagues from Newcastle shown here, which relates to the age at which somebody stops walking with Duchenne muscular dystrophy being a function of being very closely related to how well their heart is working. So if you just gone, that's brilliant. So as well as affecting research, this problem also affects service delivery. So for a clinician looking after a group of patients, it's really difficult to know who's affected, who's the most severely affected, and whether or not the care that we are delivering meets guidelines. One hopes it is, but it would be nice to see that, in black and white. From a patient's perspective, it can often be difficult to get hold of the information they need to know whether or not their condition's getting worse. And all of which is to say that if Paul Wood were around today, I don't think he'd be very impressed by the lack of progress we've made since he was practicing. So to start to address these problems, you need to try and access the data. First, you need to find the relevant database. On your left-hand side is one of 12 solid gold eggs hidden by Cadbury's in the mid-80s as part of a national treasure hunt that gripped the nation. And I have to admit, trying to find out where patient data is stored has had a similar feel to a treasure hunt. So it's sort of equal parts excitement, frustration, and hopelessness. And when I first started in Birmingham, I went from person to person trying to get clues as to where the data was held until I eventually found the relevant databases. But even then, it was impossible to access them. And I have to admit that I gave up for a period because it was just, it was too dispiriting.
So Will's talked about this data as treasure, and it is treasure. It's something that really needs to be nurtured and cherished. It's incredibly important. But to find that information often feels like a bit of a quest. To pull together the data I'm about to show you, we have to bring together our own fellowship, a team of highly knowledgeable people with specialist skills in informatics and data wrangling. And we need a champion at the center, like someone like Will in the middle of it all. And this is a big part of service design, is bringing these people together and then building those kind of trusting relationships where they're willing to actually go on this quest on our behalf. So, sorry, I'm just going to wait for that to load up so you can see what I'm looking at. So one of the challenges we were looking at with Duchenne patients is the fact that it's quite difficult to have an accurate, up-to-date list of patients living with this condition, particularly as they transition from children's services into the much more complex ecosystem of adult services. As Will said, these are people who need to see multiple specialist services. And when they move from children's, where everything's kind of in one place around them, they're suddenly going to a place where all those services are in different places. So I'm sorry, my screen's not loading. I cannot play this video again, but hopefully what you saw there was a dashboard. So one intervention we're looking at is bringing together a clinical dashboard that does 4 things. It defines an accurate patient list, so everyone we know is living with Duchenne, help us identify which patients are due an echocardiogram and when to book one, or if they've previously missed one. For people whose hearts are affected by their condition, are they on the right medications? And get a helicopter view of the population and drill down into its wider needs to smooth that transition between children's and adult services. Now, you might think a dashboard's not that revolutionary, and designing a dashboard really isn't that revolutionary, but getting all that data in the right place, it's kind of hidden in the fiery pits of Mordor. So the real work is around bringing those people together to understand what data we need and put it in one place. And as Will showed with Paul Wood's notched cards, he was limited by the size of the periphery of that card as to how many different things he could measure. So he was constrained in terms of what data he could contain there. But this constraint can be a really beautiful thing because it cuts out the noise. So what we're doing with this kind of dashboard is an attempt at creating the constraints that open up those golden nuggets of information at exactly the right moment for clinicians.
Hey, thanks, Laura. So, yeah, the next theme was try and be a goat when going about this work. So, excuse me, we've now been working with Unboxed, as I mentioned, just over 2 years, and it's fair to say that it has felt a lot like this experience. You know, very steep cliff edge. We're trying to do, hopefully, ambitious and things that will make a difference. And at every turn, as you would expect, because it's not straightforward, there's some sort of obstacle. So it's meant that we've really had to be very agile about the way we're going about things. And I think what's been useful from my perspective is sort of changing certainly my attitude towards how change happens and how it progresses. So several things have emerged. The first thing is sort of meeting people where they are rather than where you'd want them to be. So, you know, in a very literal sense, that might just be, okay, we've got a person we want a question answered from. How do we get a hold of them? Well, let's just pick up the phone or maybe go down the corridor where they're doing clinic and just nab them very quickly to get their feedback on something. The next thing has really been to focus on momentum and where we're going to get the most traction. So, for example, at the moment, there's a great deal of interest in screening as part of the prevention agenda and also genomics. So we've really tried to leverage that as much as possible by building out our profile, but also engaging stakeholders. Another factor has been to really understand the trust procurement process. And I think for all of us, some of the most eye-opening conversations we've had has been with members of the IT and digital team, and just understanding the challenges they're under managing literally thousands of different products. And for a period, this definitely did block our progress, and we had a couple of rejected grants to the British Heart Foundation looking for money to build out our prototypes, but with a big stroke of luck, the Trust has just engaged a digital software builder. So we're in the process of essentially seeing how well we can take the vision and prototypes that we've developed during the scoping and prototype phase and build them out. So luck is definitely required as well. Another thing that's been very timely is this government-promoted approach to public service reform called Test, Learn and Grow. And that's been really important because although we're talking a lot about the operational infrastructure to improve service delivery, we also need a different way of working in order to be able to build out and develop that approach and run the service effectively. So if you like, if you haven't come across it, there's a blog on the topic. There's a LinkedIn community that I think now has over 1,000 people on it. And there's also a list of rules which you can go through. There's a number of different principles. But one of them is just start really small and take very small steps. So that was great for me because it gave you the sense that you can get some sort of purchase on what otherwise seem like intimidatingly big problems. Another principle is to design for scale from the outset. And I think from our perspective, the idea that there is a home in the NHS app for something that we're building, if we can get the pathway right, what works in Birmingham for 95% of cases should work elsewhere in the country. So that gap becomes invitingly small between what you do at a local or regional level and what you do nationally.
So I just wanted to touch on something we talked a bit about, but what's really fundamental to service design. So that is about having a multidisciplinary team. As a service designer, I I often standing in a room with lots of very smart people having conversation around me thinking, what am I actually contributing here? But actually that's the bulk of the work we do is finding those people. We start with a core team here. You can see myself, Saskia, Will, Alice, who's our clinical nurse specialist lead on the project, Andrew, our developer, Molly, operations manager, lots of other people. We're in a core team, which kind of snowballs out. We all know healthcare professionals are very, very busy. They're often focused on their bit of the system because they just need to get in and get their job done. And it's quite hard to put their head up above the parapet and see who's wrangling with the same problem they're dealing with. So we have this really useful role in coming in and sometimes asking the questions that are very obvious, but no one's had time to ask, and facilitate some of those conversations and relationships. And we just can't do change and innovation in healthcare without a multidisciplinary team with a really wide range of skills, and constantly growing that team and finding the people who can unlock the next piece of the puzzle. So we're just going to really briefly touch on what it's like to work across this kind of team. Saskia, over to you. Oh, we lost Saskia.
You're on mute, Saskia.
Unmuted, sorry. Yes, so working with clinicians is obviously integral to this process. Collaboration's something that's really important to us, as you can see in this picture. Getting everyone in the room, getting ideas out. We always like using a lot of post-it notes as well. Clinicians are really important people to have there because they bring a huge depth of experience and are deeply committed to improving outcomes for patients. But one thing I think that's important to touch on is that clinicians are also shaped by their training in environments they work in. They're taught to make decisions quickly in really high stress environments. They rely on processes and carry significant responsibility. In the NHS, they're often under enormous pressure, and this gives them little headspace of thinking differently and in a system where change is frequently imposed from above. So part of our job is to create environments where it's okay to explore and making experimentation feel less risky to them. One example of this, which I think was quite interesting recently, me and Laura went to the National Orthopaedic Conference hosted by Orca. And what was interesting there is that really showed there wasn't a lack of creativity within clinicians or desire to improve care. We ran a workshop to kind of explore current challenges and possible solutions. And some people in the room felt overwhelmed by the scale of problems that they face and felt really entrenched in the systems that they're in. Kind of, we had questions like, where do I even start? And part of our job was breaking that down and looking at where to start and how to even start exploring these issues. And this then thus created a lot of energy and opportunity to rethink how clinicians can bring back some control and build around the system that they work within. As designers, our role isn't to impose change, it's to create trust, permission and structure to allow clinicians' expertise, creativity and desire to improve care can be channeled to create meaningful change. Another thing that I think is interesting to touch upon is founders, and also another aspect of this is working with people with lived experience, because another healthcare project I worked on was around Parkinson's, where I was working with a founder, also a CTO and a head of marketing that all had Parkinson's themselves. Their personal connection to the problem created like an incredibly motivating atmosphere and a strong sense of purpose within the team. But I think an interesting thing was working around a founder's passion and story and bringing people together and going out and connecting user research with an idea. When a mission is deeply personal, sometimes boundaries between work and life can be blurred. This can create burnout sometimes. This isn't just about the product that we're building, it affects them every day, the people I was working with that had Parkinson's. And while passion's a huge strength, it can also, as I said, create some risk of burnout. So I think checking in is really important part of the process, particularly when you have lived experience or are working with quite intense situations sometimes. An important thing to remember is that as designers, we're not just designing products and services, we're working with people. So regularly checking in with the internal team, with people we're working with, clinicians, is really important, and understanding people's physical and emotional needs and adapting to this is really important and part of the process. One of the other things, particularly with working with a founder, is he came to us with a 50-page presentation of a very fully formed idea. And part of our role wasn't to challenge his ambition, but to kind of respectfully break it down and help identify where to start and connect him with what the users needed. So going on from this, another part, sorry, Laura, if you go to the next slide, is personal experience versus user experience. And so what I was starting to touch upon was someone can bring a very strong perspective to the table, but a part of our job as designers is to connect it with the user experience. As I was mentioning, the strength of working with founders with lived experience is the empathy and passion they bring, but lived experience doesn't automatically represent everyone's experience. Particularly in that project, there was an assumption from the founder that other people with Parkinson's would approach their diagnosis the same way he had. And that was in a very proactive way, as what I was saying earlier about how people respond very differently to their conditions. He came out into the project thinking that people would want a lot of information and understand a lot of things about their condition. But a really key part of this process was I did some user testing at a Parkinson's UK group in Royston and had him come along to the session. And what was interesting about that is that showed very tangibly a very wide range of responses to how people approach their condition. So one person in the room, he had come just for that day and he just came for a cup of tea and a chat. He didn't really want to get involved in talking about his condition. And I think that was a really important part of the process, is understanding the variation in how people view their own conditions. Yeah.
Over to you, Will.
Right. So just a few words on what it's like to work with service designers. And I will just leave you with this animation. It's been a really, really positive experience, and it's certainly, I would say, re-energized my interest and career. I think trust was mentioned, and that's one of the big things that I've come away with is being able to work with folk who engender that trust in my colleagues has been tremendously helpful, because it just makes the whole process that much simpler. I've learned an enormous amount. They've been incredibly accommodating, and genuinely, I think we've gelled into a team rather than two different entities.
Thank you. Okay, so we're just about finished. I just wanted to touch on something that was in the description for this talk. We said we'd share lessons around sustainable innovation. So we talked about a number of projects which are ongoing or in progress. Remote monitoring service was live for many years, but no longer exists. So why are we talking about sustainable innovation? So we're just going to touch on what we think that means. That's
Right.
Will.
So I wanted to put this paper from the 1960s on because it's a sort of touchstone of organisational science. So it's a piece of work where Isabel Menzies here went into a very large teaching hospital in central London and looked at how the nursing service was organised. And she came up with this principle that the nursing service had evolved in a way as a defence against anxiety. And I think that was, having a look at this paper and understanding the context has reminded me just how stressful working in healthcare is. You know, there's a lot that goes on that's really troubling, and it makes people behave in odd ways, and it makes groups do odd things. And you know, for example, earlier today I was reporting MRIs, and I could feel myself wanting to report the MRI a specific way in a certain order, and it's almost like you're trying to protect yourself against something going wrong. And the work we've been doing with Unboxed was really brought home to me the sense that you need to create a container for that anxiety. Because very often, and I've certainly felt it in the first project and to a latter extent the second project, we get to the messy middle and I'm like, when does it all become clear? And I wanted that reassurance, as did my colleagues, that there was a clear plan, and we knew what the answer was going to be when we started, and obviously that's not how this process works. But I can safely say that you know, working with service designers has allowed us to create that sort of containment space where we can start to reflect, be creative, and to properly think how best to serve our patients.
Okay. Thank you, Will and Saskia. That is it from us. We're looking forward to taking your questions. We'd love you to connect with us as well. If what's on the screen are, if you scan those QR codes, you can connect with us on LinkedIn. But I'm going to hand back to Jesmond for our Q&A.
Fantastic. Thank you